Good morning and hello everyone and welcome to our high yield nutrition webinar for step 2 and step 3. My name is Dr. Karim and I will be going with you through this webinar. I scored 279 on my step 2 exam and I have been tutoring USMLE for about 5 years now. Now, as you may know, there was recent changes in the USMLE that they are going to emphasize more on the nutrition part and we are going to address these specific concepts. We are going to go through about 20 high yield questions and going through these 20 high yield concepts that we think can be emphasized. Of course, I believe this webinar will also be very useful for step 1 students because most of these changes emphasize on the nutrition, which is mostly biochemistry. So if you are a step 1 student attending, of course, I believe 80% of these questions would be relevant to you. Okay. Now, let's just get started. And I believe again, if you like this specific session or this specific webinar or any of the other webinars, make sure to subscribe to our YouTube channel and make sure also to check out our high yield crash course that we cover everything that's important or remotely high yield in step 1, step 2, and step 3, and it's money free or like um, it's risk free because you can just get your money back if you are not satisfied after the first day. Now let's start. Okay. Now, as I usually do in the course, I would emphasize, guys, that just to try to participate with me, ask questions. I am always looking at the chat. Okay. So whenever you have any question or whenever you have an answer, just try to participate because it's usually easier for your mind when you answer any question, either right or wrong. This information will stick into your mind more. Okay. So let's get started. The first question is telling me that we are having a 28-year-old woman with a BMI of 14.5 and anorexia nervosa. She's started on enteral nutrition. On day 2, she develops a confusion, muscle weakness, and tachycardia and a prolonged QT interval. And they are asking what electrolyte pattern is expected here. Is it hypophosphatemia, hypokalemia, hypomagnesemia? Is it hypernatremia? Is it hyperkalemia and hypermagnesemia? And what do you think this person have here? Amazing, Summer. Amazing, Sarah. Very good, Nazaris. Amazing, Kara. Amazing, Mirza. So for this one, guys, I will try to give you like how do I think about this question specifically. Okay. First, of course, it would be refeeding syndrome for few reasons. The first reason is that when I'm reading the question and they are giving me a very low BMI person, I start to think about two things. Either this person is starving because they have any disease that can cause starvation. For example, let's say they have marasmus or they have kwashiorkor, which is very rare usually in developed countries, or this person is usually having an eating disorder. For example, they are having anorexia nervosa or bulimia nervosa. Now, usually, how do I differentiate, even if they didn't tell me that this person is having anorexia, is that anorexia nervosa will have low BMI, right? So if you see that the BMI is equal or less than 17, you know that it's usually anorexia nervosa, okay? Because below bulimia nervosa will usually have a normal BMI. The other thing is that they told me that this person is having a muscle weakness and a prolonged QT interval. Whenever I see muscle weakness and prolonged QT interval, I start to think about decreased potassium, hypokalemia, usually either hypo or hyperkalemia. Both of them can cause muscle weakness, but hypokalemia specifically will cause prolonged QT interval like this, what this person have. Okay, of course, you know, guys, that when you think about it, what is the QT? The QT is usually the space between the QRS complex and the T wave, which is here, between here and there. And this is usually the amount of time that takes the heart to repolarize. And if you may know from the cardiology of step 1, that the way the heart repolarize is that potassium will go out, right? Now, if you have hypokalemia, It will take too much time for the heart to repolarize. So that's why the QT interval will be too long. Now, how you can get this problem? You can get it either from hypokalemia, or if you have problem in the potassium channels. Like for example, there is diseases called Roman-Ward syndrome or Jarvel and Lange-Nielsen syndrome. These diseases are problems in potassium channel and they can cause prolonged QT interval. Or you can get it from drugs. As you may know, there are some drugs that can be similar, for example, to erythromycin and the macrolides. Like, for example, antipsychotic drugs. So there is some drugs that can also cause prolonged QT interval. And the problem with prolonged QT interval is that it will usually cause the person to have torsade de bois, which is usually this like irregular QRS wave that elongates and gets smaller again and whatever, torsade de bois. So here we know that this person is having hypokalemia. We also know that usually when you start nutrition in general, what happens is that you give them glucose, right? And when you give them glucose, insulin will rise. And when insulin rise, do you know what happened? It will drag the electrolytes inside the cells. So it will decrease the electrolytes in the blood. And that's why this person develops hypophosphatemia because the potassium goes inside the cells, hypokalemia, and hypomagnesemia. You can see it in people with anorexia, or you can also see it in people with alcohol syndrome. Right, guys? Alcohol syndrome. So that's the three things that I wanted to tell you about. And we usually call this problem refeeding syndrome. It happens when you have a person that's starving, for example, an alcoholic person, or a person with anorexia, for example, and you start to give them feeding. Then what will happen is that you start to give them glucose. The glucose will cause insulin to increase, and the insulin will drag the electrolytes inside. So this will cause hypophosphatemia, hypokalemia, and hypomagnesemia. Okay. Now, if I have to also answer another question, is that what would this person have, alkalosis or acidosis? Usually, people with anorexia nervosa get it from vomiting, too much frequent vomiting. So probably they will get also metabolic alkalosis. Probably they will get metabolic alkalosis, right, Mirza? Amazing. Perfect, guys. So that's a few things that I wanted to tell you about. Okay. Now, another thing that I wanted to tell you about, okay, is that again, please take care. The risk factors for refeeding syndrome is any starvation. If your BMI is very low, prolonged starvation in general, alcohol use, eating disorder, and the cancer. Now, one of the things you need to prevent is that whenever you give the person glucose, you need to give them thiamine first, and that's to prevent this refeeding syndrome and to prevent also Wernicke-Korsakoff syndrome. You also need to give them electrolytes every 6 hours to prevent hypokalemia, hypophosphatemia, and hypomagnesemia. So that's very important, and you can't believe how much on STEP exams they care about thiamine. Usually, whenever you see a person starving or a person in a coma, whenever you give them glucose, you need to give them thiamine with it to prevent Wernicke-Korsakoff and sometimes to also prevent refeeding syndrome. Okay? And of course, thiamine is vitamin B1. It's vitamin B1. Now, let's go to the next one. So we have a person intubated in the ICU and they are in mechanical ventilation for respiratory failure. They have bowel sounds and a soft, non-distended abdomen, and they are asking what's the preferred route for nutritional support. Is it enteral nutrition, parenteral nutrition, TPN, or withheld feeds for 72 hours? What do you think here, guys? Amazing, Aishwarya. Amazing, Speedy. Amazing, Niha. Perfect. Perfect, Rebecca. Perfect, Bilal. Okay. So for this one, the answer would be enteral nutrition, and I will tell you why. Okay. The first problem that the students fall into is that when they see a person in the ICU, they say, "Oh, like this person is like he is severely ill," and they have this misconception that a severely ill person means that you need to do parenteral nutrition for them, which is usually incorrect. The way I think about it, guys, is that parenteral nutrition, which usually literally means you are introducing the nutritions here in the arteries and the veins so it can go to your body. We only use this if you are completely unable to have anything per mouth for too many days. If you have this problem, then maybe parenteral nutrition will work out. But it usually goes like this. Whenever we have a person that we need to feed him, we start first by feeding him by mouth. Then we can try the nasogastric tube. Then if they can't take nothing per oral, but for 1 day, for example, so it's acute, they can, let's say, for example, they have hyperemesis gravidarum, which is too much vomiting during pregnancy. These people, they can't take nothing per oral, right? So we can give them IV fluids. But and for example, dextrose. But when we say parenteral nutrition, it means we are giving all the nutrition, the carbohydrates, protein, fat, everything through the blood vessels. This is usually the last action. So the last line treatment or the last way to feed a person is by parenteral nutrition. It's when we exhaust all the other situations. And it's usually the last thing we do. It's usually the last thing we do. Okay. Now, so how would they describe the person to us where the answer would be parenteral nutrition? I don't want you to answer this question unless they tell you we tried enteral nutrition and it failed. Okay, that's a very important summary. So please, guys, let me tell you something. In 99% of the situations, parenteral nutrition will be the wrong answer on the exam. That's it. Okay, don't choose parenteral nutrition. That's very important. The reason behind this, Mirza, because you told me why, because parenteral nutrition first, you are giving the food here in the blood vessels. This can cause septic shock. Oh, thumb up. Okay. This can cause septic shock. And that's the most important complication. The other thing that parenteral nutrition would do is that it means when you give the person blood through his arteries and veins, it means he is not using his GIT anymore, right? His gastrointestinal tract. So the gallbladder would be inactive. And this causes gallstones, right? Cholestasis, amazing, because his gallbladder is not working. And that's the two most important complications, and that's why we don't love parenteral nutrition. We start with enteral nutrition. Okay, that's the thing. So I don't even care about parenteral nutrition, whatever they are trying to give us through here. And of course, I can't withhold feeds for 72 hours. That would be insane. So here it would be enteral nutrition. Okay. Now, the other thing, after IV fluids and dextrose, Nathania, we said the last action would be parenteral nutrition, but again, I don't want you to choose it in the exam unless you are pretty sure that's the only option you have. Okay. Now, the other thing that I wanted to ask you, which is a trick question. A person with Alzheimer's disease and he is having difficulty swallowing, what should you do to give him food? A person with Alzheimer's disease have difficulty swallowing. Should you still give him per oral small frequently of food, or should you do nasogastric tube? What do you think? That's that's the thing. Nasogastric tube would be the wrong answer in the exam. Nasogastric tube would be the wrong answer on the exam. Because what are you afraid of in a person with Alzheimer's disease? You are afraid that they are getting to have abscess or like aspiration pneumonia, right? Amazing. Perfect. Isn't nasogastric tube, guys, you are literally putting the tube in his throat. This can also literally have the same risk of increasing the risk of aspiration pneumonia. So it wouldn't be that helpful. What you should do in a person with Alzheimer's disease, because it would be very good for his function, okay, his well-being, and also it's very good for the long-term management, is that you will do swallowing assessment and you will just give him small frequent liquid formulas of feed per oral. Don't do nasogastric tube. Okay. And as Mirza said, you can't give nasogastric tube for long term. Okay. So please, guys, people with Alzheimer or people with dementia that they have dysphagia or problems swallowing, you still give them per oral but small, thickened, thick liquid food. Okay, so that's very important. Yes, second, the liquid food. Okay, using a straw will be wrong on the exam. You can't use a straw. A straw will usually cause more aspiration. Okay, so straw is wrong on the exam. Another thing that's wrong in the exam is that they will tell you observe him while he is swallowing. So you can give literally you can get a nurse to start sitting with him to observe him while he was swallowing. That's also wrong answer because it's unfeasible and it's unnecessary and it's useless. What would the nurse do if she is just observing him trying to swallow? So the only thing that would be work is thickened liquid formulas. They will start to take it one by one and you will do swallowing assessment. Okay. Now, again, please, enteral nutrition is very important, guys, because parenteral nutrition is like can cause sepsis, septic shock, and all of this other stuff. Okay. Yep. Long-term nutrition are never nasogastric tubes. That's the thing. Amazing verse. Now, let's see here. A 62-year-old man with type 2 diabetes on metformin for 8 years, presents with fatigue and food paresthesia, and MCV is 100.4. Folate level is normal. What's the most likely cause of this macrocytic anemia? But let me ask you a question. Why? Not the cause, but why they are having this macrocytic anemia? Like, other than the answer itself, what's the reason behind this? Okay, amazing. Amazing Helena, amazing Muhammad, amazing Merz. Perfect, guys. Perfect email. So for this one, if I'm going to speculate here, okay, usually guys, metformin itself, okay, can cause vitamin B12 deficiency. That's very important. Okay, that's very important. And the reason behind this is that it prevents its absorption. So long-term metformin can cause B12 deficiency. And this can cause neurological problems, like for example, paresthesia. And this can also cause megaloblastic anemia because it will cause problems in DNA synthesis. Okay. Now, even if they told us that folate level, even if they didn't mention folate level, I know it's this megaloblastic anemia is from the B12 itself because they mentioned the paresthesia here. And that's why you can see sometimes in practice, they give diabetic people B12 for two reasons. First, B12 is good for the nerves, right? And usually diabetic people, they have peripheral neuropathy. And the second reason is that they have a high tendency of having B12 deficiency because they are usually on metformin. Okay, so it would be B12 deficiency here. Now, another thing that I wanted to ask you, okay, or I wanted to state, you have three other ways to get B12 deficiency. The first way is that in order to absorb B12, you need to have intrinsic factor, which is secreted from the parietal cells. Amazing. So usually you can get, as Mohammed mentioned, a disease called pernicious anemia. This disease, you are having an antibodies against the intrinsic factors and against the parietal cells, which can cause B12 deficiency. The second way to get B12 deficiency is that if you have problem at the terminal ileum, because usually you absorb B12 in the terminal ileum, for example, as Herdig and Sides, Crohn's disease. Yep, Crohn's disease. The third possible way uh, of getting it, okay, is from an infection that can cause eosinophilia, and this infection is a parasite which is usually called D. latam. Yes, D. latam. It's called as a fish worm, and it can cause B12 deficiency. Okay, and the last way, which is very rare by the way, is that if you are a strict vegan, because B12 usually come from animal products. So if you are strictly vegan, you can have B12 deficiency after years because it's usually stored in the liver for 5 years. Okay. Now, so take care of this parasite called D. latam can cause B12. What parasite can cause iron deficiency anemia? Because they can cause bleeding in the GIT. Not ascaris specific lemurs. Ascaris can cause very rare bleeding, not ascaris. The hookworm, amazing. Um, there is two ones, something called ankylostoma, and the other one is called the Necator americans. Necator americans. Ascaris can affect the GIT, but it wouldn't cause bleeding. Giardia will also not cause bleeding, Sarah. Giardia will cause fat malabsorption. So the two ones are ankylostoma, and the Necator americans. These ones will cause iron deficiency anemia. Okay? So take care of the difference between D-latam, B12, and iron deficiency anemia, ankylostoma, and Necator. We also said Crohn's can cause B12. But what disease can cause iron deficiency anemia? Because it will affect the duodenum, because you absorb iron from the duodenum. What do you think, guys? There is a disease that can affect the duodenum, can cause atrophy of the villus, and can cause iron deficiency anemia. Amazing. Perfect. Perfect, Iman. Perfect, layman. So it would be celiac disease. Whenever I see in the question a person with celiac disease and diarrhea, I always think about, a person with diarrhea and iron deficiency anemia, I always think about celiac disease. Whenever I see a person with diarrhea and iron deficiency anemia, I always think about celiac disease because celiac disease affects the duodenum and you absorb iron from the duodenum itself. Okay, so these are few things I wanted to highlight for you about B12 and about iron and the differences in the exams that they can ask about. Okay. Now, take care that this session will be recorded and it will be on our YouTube channel. I will also upload the PowerPoint, this annotated one and the original one in the YouTube channel description. Okay. Now, let's see here. Yes, Malva. This person have B12 because long-term metformin use. As you can see, when we are discussing questions, we are not only discussing the answer choice, we are trying to go through what all of the ways they can ask about in the exam. Now let's see this one here. As a 70-year-old man on warfarin, his INR, which is the international ratio, which is usually similar to the PT, is stable at 2.5. Suddenly, he increases his intake of green leafy vegetables. His INR drops to 1.4. What's the most likely cause? What do you think, guys? Amazing, Madia. Very good at Chania. Amazing. AMD. Perfect, Sarah. I will, Sylvester. Amazing, Nora. Perfect, Maria. Perfect, Rebecca. So for this one, it would be A. Amazing mind. I can see that 70% of the people answering with me, they were also with me in the previous webinars we have done or from the crash course. So it's a very good, guys, to see that you are very persistent with me. Amazing. So here, warfarin itself is usually used as an anticoagulant. And the way it works is that it usually inhibits the activation of vitamin K. It inhibits an enzyme called epoxide reductase that's important to activate vitamin K. And we know vitamin K is important for the gamma carboxylation or for the activation of the coagulation factors 10972. Okay. Now, a very important thing that I want you to know is how we make vitamin K. So usually we get vitamin K from two important resources. The first resource is leafy vegetables. Leafy vegetables. The second resource is usually amazing, the GIT bacteria, the gut bacteria. So this can be a way to test us, and they can ask maybe 3 or 4 questions about it. I will tell you all of them. Okay. The first question, guys, is that if you are taking green leafy vegetables, this can cause increase in vitamin K, and that's why this person is having decreased INR because they are now having too much vitamin K, which is the antagonist to warfarin. Okay, so they are taking increased dietary vitamin K. This one is easy, but there is other questions they can ask. The second question they can ask is that if you are taking warfarin, don't take antibiotics with it, right? The first reason because this can kill the GIT bacteria, and this can cause vitamin K deficiency, which will mess up with the warfarin dose. The second cause is that many antibiotics can mess up with the cytochrome B450, right? For example, they can be an inhibitors or inducers, and this can also mess up with the warfarin dose. So, like for example, macrolides. Macrolides are cytochrome B450 inhibitors. So they can cause increase in the warfarin level, and this can cause more bleeding. So take care, guys, that be careful with antibiotics intake when you are having warfarin itself. Okay. Now, another thing that is very important on the exam is newborns. Newborns, especially preterm kids, they don't have GI bacteria. They have a sterile gut. And that's why they have vitamin K deficiency. And that's why any newborn, you need to give him 1 dose of warfarin, okay, at birth. Any newborn, you need to give him an injection of warfarin at birth. Okay, so that's very important. That's very important. Now, I will answer some questions and I will go to the second one, but I need you to take care. How do we get warfarin itself? Okay, vitamin K injection, yes. Vitamin K injection. Yes, sorry. Of course, not warfarin injection. Yep, yep. Okay, let me answer these questions. Sylvester is saying rifampin is inducer. Yes. You are asking guys about easy ways to remember cytochrome B450 inducers and cytochrome B450 inhibitors. Okay. And usually the way I remember it, okay, is that the inducers will have the word V on them or F. That's just a funny way to remember inducers. For example, rifampin, F. Okay. For example, phenytoin, F. And the other anti-seizure, which is carbamazepine. Okay. For example, there's like these drugs that for HIV, the NRI, they are called nevirapine or whatever, okay? The NNRTI. So usually I remember the ones that have F or V. You will try to like open any resource that has inducers. They will have the character F or V. You will know they are inducers. Then I remember the other ones are inhibitors. But this is out of the scope, of course, of the session, okay? And rather also it's an ethics question. If parents refuse, you will try your best to convince them. It's not mandatory because it will not cause immediate stress, unfortunately. So you will have to try your best. It's similar to vaccination. Okay. Now, let's go here. So sudden increase in vitamin K because you gave him vegetables. This caused decrease in the INR, and this can cause thrombosis risk. Okay, so take care. Usually, when you give vitamin K rich foods, like for example, kale, Spanish broccoli, all of these green vegetables. Okay, now let's see here, guys. A 35-year-old man with HIV and poor nutritional status is started on isoniazid for latent TB. What supplementation is indicated to prevent a common adverse effect? What do you think here, guys? Amazing Summer. Amazing Abido. Very good, Helena. Amazing Nazareth. So take care for this one, guys. There is few things that I want you to take care of. Okay. The first thing is that whenever you are having like latent TB, remember you either treat it with isoniazid or you treat it with rifampin. The problem with isoniazid is that this can cause vitamin B6 deficiency. Okay. And when it causes vitamin B6 deficiency, this can cause peripheral neuropathy. And do you know what type of anemia B6 deficiency will cause? Very good. Very good. Remember, vitamin B6 is important in synthase, guys. It's important in an enzyme called synthase, which is important to make hemoglobin. And that's why if you have B6 deficiency, you will have problem in synthase and problem in protoporphyrin synthesis. This can cause sideroblastic anemia. Karim, why you are telling me this? Is this important on the exam? Yes. I will tell you where is the trick here. The trick here is that latent TB, isn't this a chronic inflammation, guys? So it can cause anemia of chronic disease. And then isoniazid can usually cause sideroblastic anemia, which is usually a drug we give for TB. So the question is, sometimes the people with TB can have two types of anemia: anemia of chronic disease and sideroblastic anemia from isoniazid take. Now, sideroblastic anemia would be usually microcytic, right? And you will have too much serum iron because the problem is protoporphyrin. You can't make protoporphyrin, which usually bind iron. So what will happen is that iron will accumulate because you don't have protoporphyrin. On the other hand, anemia of chronic disease can be either normocytic or sometimes rarely microcytic, and it will usually have low serum iron but high ferritin. So take care, that's the trip in the exam. Is that you see a person with TB and they are having anemia. You think, oh, B6, B6. No, it can be anemia of chronic disease. So think about the serum iron itself. If it's a high, it's a sideroblastic. If it's low, but the ferritin is high, it's anemia of chronic disease. Okay? That's one of the tricks of the I can ask about on the exam. B1 is wrong. B1 is usually deficient in people that are severely malnutrition, like alcoholics. B3 is wrong. B3 is usually important in people that are having, let's say, serotonin syndrome. We'll talk about it. People that have, let's say, um, or carcinoid syndrome, people that are having corn-based diets, people that are having something called tryptophan malabsorption in general, okay, like heart valve disease. So all of these causes, it can cause pellagra or the 3D, diarrhea, dementia, dermatitis. And the last one is vitamin A deficiency. It's also very rare to get vitamin A deficiency because vitamin A is found in the liver, it's found in meat, it's found in vegetables, green vegetables, and it's very rare to be deficient in vitamin A. So here's the answer was B6, guys. Okay, isoniazid itself, it inhibits something called the pyridoxal phosphokinase that deplete vitamin B6. Remember, vitamin B6 is called the pyridoxine. And that's another important stuff. I need you to know the enzyme name, not only B6, B7. I need you to know the name B6 pyridoxine, B7 biotin. So take care of the names, you guys, not only B6 or B5, because sometimes the answer choices will contain the names, not the numbers. Okay? So that's the important stuff about B6 itself. Now, isoniazid can cause B6 deficiency. Now, let's go through this one. That's here minerals. They're asking about selenium, zinc, copper, niacin, biotin, but mostly minerals. So a young boy develops a chronic diarrhea, perioral and acral dermatitis, alopecia. There is decreased sense of taste after being weaned from breastfeeding, and there is delayed sexual maturation. Which of the following best explains this patient condition? Amazing Hardik, amazing KG, very good Nathania, amazing Muhammad, amazing Rebecca. Perfect, guys. Perfect. Perfect. So for this person here, it would be zinc deficiency. And the reasoning behind this, guys, okay, the reasoning behind this is that the way I think about zinc is that I think about it affect the mouth and the anal canal. The mouth and the anal canal and the genitalia. That's how I remember it. So it affects the two openings, the mouth and the genitalia and the anal canal. So when it affects the mouth, it will affect the taste and it will cause rash around the mouth. When it affects the genitalia, it will cause rash around the genitalia and it will also cause sexual problems, okay, like delayed sexual maturation, for example. That's how I remember zinc. It affects the two openings, the two opening orifices, the mouth and the genitalia. That's how I remember it. So this person, can you see, have problems from the genitalia and the anal canal, diarrhea, okay, and have problem from the mouth, perioral dermatitis, taste problems, okay, have problem around the genitalia, delayed sexual maturation, then I know it's zinc deficiency, okay. Now, another thing I want you to know about zinc deficiency for step 2, okay, is that it can cause copper deficiency if you take an excessive amount of zinc. So if you are taking excessive amount of zinc supplements, this can cause copper deficiency. And the copper deficiency itself can usually cause problems like anemia, something called myeloneuropathy, which is peripheral problems in general, similar to B12, and it can cause like hair problems. Okay, but to be honest with you, when I think about this minerals deficiency, I need you to know the high yield facts only. So I need you to know for zinc, problems around the two openings, the anal canal genitalia and the mouth. When you think about selenium, I need you to think about the hair. When they start describing you a person with hair abnormalities in general, think about selenium. Okay? When you think about selenium, also think about the heart. It will cause dilated cardiomyopathy. So selenium affects the hair and usually affects the heart. Okay? When you think about chromium, think about hyperglycemia. They will tell you a person have hyperglycemia resistant to insulin. So no matter how much insulin you give them, they still have hyperglycemia. Think about chromium. That's the keywords. Okay. When you think about fluoride, think about dental caries. Usually, guys, the water that we drink is having fluoride because we do fluoridation from it, right? So how would the question come up on the exam? How would you get fluoride deficiency? They will tell you the kid is drinking from wells, from a well. And usually a well water is not processed, right? So it will have no fluoride. So they will tell you they are now having dental caries. What's the cause? It's because they have fluoride deficiency. Okay. That's all of the important stuff. Last thing is manganese itself, or manganese, sorry. Manganese itself, toxicity of it can cause Parkinson-like symptoms. Okay. Similar to copper also. Copper overload can cause something called Wilson disease, which can cause Parkinsonism in young kids or young people. When you see Parkinsonism in a young patient, think about copper problems, copper accumulation, or sometimes manganese accumulation. Okay, guys? But that's only the keywords. Again, minerals in general can cause very non-specific symptoms, right? And that's why if you try to focus on every little details of minerals, you will get the question wrong on the exam because they are overlapping with each other. So just to try to get the keyword here and there and move forward. Okay, that's important. Now, let's go here. So the answer was zinc deficiency. That's the most important mineral deficiency. Okay, guys, zinc deficiency. Now, let's go here in this one. A 32-year-old woman with chronic diarrhea, iron deficiency anemia, low vitamin D, and periodic vesicular rash on her elbows. What's the diagnosis and the management? What do you think? Amazing. Perfect, Hania. Amazing تفاعل. Amazing Anno. Perfect, guys. Perfect. Okay. Amazing. So this person here, guys, they are having celiac disease. Okay. Why it is celiac disease? First, we know that the person is having chronic diarrhea. And we know celiac disease can cause malabsorption, which can usually cause chronic diarrhea, especially fatty diarrhea, because it can cause fat malabsorption. The second thing, iron deficiency anemia, right? Because we know celiac disease affects the duodenum. And remember, what did we say? Whenever you see diarrhea and iron deficiency anemia, always think about celiac disease. Okay? Then it will also cause low vitamin D from the fat malabsorption. Remember, fat malabsorption will cause problems in the fat soluble vitamins, ADEK. Okay? And the last thing is that it will cause vesicular rash on her elbows. And the reason it will cause vesicular rash on her elbows, because that's whenever I see vesicles, I think about herpes. But when vesicles are usually in the extensors of the elbows, I think about herpetiforme, a rash similar to herpes rash, dermatitis herpetiforme. Okay, guys? So here that's celiac disease. That's very important. Your next step of management is that you need to check the anti-tissue transglutaminase antibodies, and you need to prevent gluten from the diet. You need to do gluten-free diet, strict gluten-free diet. Okay, guys? Now, other things I want you to know. Didn't we say celiac can cause vitamin D deficiency? So this can cause osteomalacia. So you need to do DEXA scan. Very important. In step 2 and step 3. This is for step 2 and step 3 people, not step 1. Okay? The second thing is that celiac disease can also cause too many infections because you are having malnutrition. So you need to give them a streptococcus vaccination. Streptococcus pneumoniae vaccination. These are two new questions they can ask you about in step 2 and step 3. You need to do DEXA scan in celiac people. You need to give a streptococcal pneumonia vaccination. Okay? Just whenever you diagnose them, Rachel. Okay? Um, Now, let's go here. A patient with chronic pancreatitis has foul-smelling greasy stools and weight loss despite adequate food intake. Okay? What's the treatment here? Is it pancreas enzyme replacement? Is it low-fat diet? Is it lactose replacement therapy? Or is it increasing the caloric count? What do you think in this one? Amazing, Mary. Very good, Bijal. Amazing, Rebecca. Amazing, Stavidia. Amazing, Lemon. B. Very good. Very good, KG. So for this one, guys, let me tell you something very important. The difference between acute pancreatitis and the chronic pancreatitis is extremely important. Acute pancreatitis will usually cause severe epigastric pain and it will cause increase in the pancreatic enzymes, right? Because usually the pancreatic enzymes are spilled out in the blood and they are accumulating in the blood and that's why it's increased. On the other hand, the chronic pancreatitis will cause chronic inflammation of the pancreas. Your pancreas is not working anymore. And this will cause enzyme deficiencies. So decrease in the pancreatic enzymes. Okay? And that's why people with chronic pancreatitis, the best way to prevent complications for them is to give them pancreatic enzymes replacements. For example, you will give them the lipase, the amylase, and the peptidase. And there was a question I remember. They were asking how to prevent the abdominal pain that's happening in chronic pancreatitis. And the answer is also pancreatic enzymes replacement. I will tell you why. When you have chronic pancreatitis, you don't have enzymes in the pancreas, right? So the pancreas is trying to squeeze out all the enzymes that's left. And when it squeezes it out, it will cause severe abdominal pain sometimes in people with chronic pancreatitis. So what should you do? You should stop this pancreas from squeezing out the enzymes left. So you give him pancreatic enzymes from outside. Now it doesn't want to squeeze out itself, and this will relieve the abdominal pain. So pancreatic enzyme replacement will usually relieve the abdominal pain that's happening in people with chronic pancreatitis. Take care people with cystic fibrosis. They usually have chronic pancreatitis, and they usually need pancreatic enzyme replacement. Okay, guys? So that's a few things. And again, remember, these are the fat malabsorption and the fat soluble vitamins you can get in chronic pancreatitis, people with celiac disease, people with cystic fibrosis, for example. Another thing that I want you to know is that these are the enzymes you will give: lipase, okay, protease, and amylase in the pancreatic enzyme replacement therapy. Okay, and you take them with food because you need to give them to absorb the food you are taking, not before food, not after food. You must take them with the food itself. That's maybe a new question they can ask about in the exam. Okay, you take the pancreatic enzymes with food. What are the causes of chronic pancreatitis? Cystic fibrosis can cause chronic pancreatitis itself. Pancreatic cancer can cause pancreatic insufficiency and can cause decreases in the pancreatic enzymes. And a surgery called Whipple procedure. In Whipple procedure, you usually remove the pancreas, you remove the gallbladder and the duodenum and the part of the stomach for pancreatic cancer treatment, and it can also cause decrease in the pancreatic enzymes, of course, because you are removing the pancreas. Okay. Now, let's see this one here. So a 48-year-old woman, 18 months after Roux-en-Y gastric bypass, present to the ED with confusion, nystagmus, and bilateral rectus pulses after 3 weeks of persistent vomiting. What's the diagnosis and urgent treatment? And what can happen if you are not treating this person? Amazing. Perfect. Perfect, guys. Amazing. Amazing, Iman. Amazing, Nietzsche. Amazing, guys. Perfect. So for this one, guys, the person is having the triad that I always love, which is usually confusion, ophthalmoplegia, and they didn't mention ataxia here. Okay, but let me add ataxia. And whenever you see ataxia, confusion, and ophthalmoplegia on the exam, like nystagmus, bilateral rectus palsy, all of this, always think about thiamine deficiency, which can always cause Wernicke encephalopathy, especially in people after ONY because they can get nutritional problems because they can't absorb vitamins and cannot absorb minerals. So this will cause Wernicke encephalopathy. Now, the Wernicke encephalopathy we said will cause confusion, nystagmus, and ataxia. You treat it with giving B1 immediately, okay? But if you don't treat it, then Wernicke can either cause coma and death, or it can cause a phenomena called Korsakoff. This phenomena can cause something called confabulation. What is confabulation? Confabulation is making up stuff, okay? Because usually with Korsakoff people, you affected a part in the brain called the mammillary bodies that make new memories, and this can cause amnesia. The people they do not remember what happened, for example, last week. So what they will do is that they will try to make up these memories. For example, let's say last week they went into an amusement park, but they are not remembering it. Then you will ask them, what did you do last week? They will tell you, for example, I visited my grandson. So here they are trying to make up new things here and there. Okay. Now, how should we prevent Wernicke? Please, guys, please, whenever you see a person malnutritioned, a person with Wernicke, a person with thiamine deficiency, you need to give B1 first. If you give glucose first, it's the wrong answer because glucose first can cause more B1 deficiency, more thiamine deficiency. So you need to give thiamine first. After you give thiamine, you give glucose. Or you can give them at the same time. But the wrong answer will always be giving glucose first. Okay? We have something called the coma cocktail that we give to people in coma. We usually give them thiamine, B1, and also glucose and also naloxone. Okay, naloxone, because they can be having opioid use. So take care, guys, Wernicke encephalopathy here. And I explained in details, Andrea, how and why you need to do glucose first before giving, sorry, why do you need to give thiamine first before giving glucose? In the step one nutrition video, if you can check it out, especially for step three, it would be very helpful. So that's Wernicke. Now, hepatic encephalopathy is wrong because hepatic encephalopathy will cause asterixis. Asterixis, okay, which is rest tremors. Um, delirium tremens is wrong. This will cause tremors in general, and this will cause tachycardia and hypertension. It happens from alcohol withdrawal, so it's also wrong. So here the answer is Wernicke. Okay, confusion, ataxia, ophthalmoplegia, and nystagmus sometimes. And take care, you need to give high dose thiamine. Okay, that's very important. If you don't treat Wernicke, you can get Korsakoff, which is usually an irreversible problem that can cause confabulation. Okay, thiamine you give it before glucose in any malnourished or at-risk patient. Giving thiamine afterwards would be the wrong answer on the exam. Okay, that's very important. Now let's see this one here. A 60-year-old man with a stage 4 chronic kidney disease has a GFR of 22 and serum potassium of 5.8. Which dietary modification is most appropriate? Is it restricting protein and limiting potassium? Is it increasing protein and potassium intake? Is it increasing sodium intake? Is it decreasing fat intake? Or is it increasing phosphate intake? What do you think here? Amazing, Rebecca. Amazing, Abid. Very good, Iman. Perfect. Perfect, perfect Alzheimer, perfect Mirza. So for this one, guys, amazing summer, amazing Maya. It would be restricting protein and limiting potassium. Okay. And I will tell you why. First, people with chronic kidney disease, they can't get rid of stuff, right? So there is many complications that can happen. First, they can't get rid of potassium. So they will have hyperkalemia. And this can cause cardiac arrhythmias, right? Very important. Second, they can't get rid of phosphorus. And that's why they can have low calcium, because if you have too much phosphorus, you will have low calcium level because phosphorus bind to calcium. And they will have something called secondary hyperparathyroidism. Okay. Third, they can't get rid of protein, especially the urea cycle. Remember, usually protein have something or a product called glutamic acid or glutamate that usually give something called NH3 or ammonia. And this ammonia in the liver, we convert it to urea, and then we send the urea to the kidney to be secreted out. So if you are having chronic kidney disease, you can't get rid of this urea. So you'll have too much urea, and this can cause too much ammonia, and this can cause something called the kidney encephalopathy or renal encephalopathy. It's similar to hepatic encephalopathy, guys. Okay. And that's why people with chronic kidney disease, you need to restrict protein. Not completely stop it, of course. It's restricted, decrease the level of it. And restrict potassium and phosphorus sometimes. Okay. Or limiting potassium and phosphorus sometimes. Now, I wanted to ask you a few questions. First question is, there is a drug you can give to prevent too much potassium in chronic kidney disease. Do you know it? Because it will prevent the absorption of potassium in the GI. Here is the two drugs that you are guys mentioning. The drug here is in the GI called the K-exalate or batriumar. Amazing, amazing. Batriumar. Okay, K-oxalate and batriumar. It usually bind to the potassium in the GI and prevent its absorption. K-oxalate or batriumar. Okay. How about phosphorus? If you have too much phosphorus, there is a drug you can give to prevent phosphorus absorption. Very good. So don't confuse them together. Sevelamer. So please, guys, if you have too much phosphorus, you need to prevent its absorption, you give sevelamer. If you have too much potassium, you need to prevent its absorption, K-oxalate or patrimar, because students confuse both of them at the same time. The second thing, if you already have hyperkalemia and you have ECG changes, what should you give right now, immediately, to prevent complications? Should you give insulin or beta agonist or calcium gluconate? Amazing. Perfect. Very high yield. Whenever you get hyperkalemia, you need to give calcium gluconate immediately. I know insulin and beta agonists decrease calcium, but decrease potassium, sorry. But the most important thing is that you need to protect the heart. You need to protect the heart. And that's why whenever you have hyperkalemia, you give calcium gluconate. Amazing, guys. So that's a few questions you can ask about in the exam. Okay. So chronic kidney disease, you need to limit protein and you need to limit potassium also and limit phosphorus. Okay, very important. Um, Also, some ways to limit potassium is to limit bananas because we know bananas have lots of potassiums. Okay, very good. Okay, yes, Charda, there is something I want you to know, guys, and that's very important. In people with chronic kidney disease, they usually die from cardiac problems like coronary artery disease, because the most important risk factors for coronary artery disease are previous history of coronary artery disease, of course, and diabetes mellitus and the chronic kidney disease. These are the most three important risk factors for coronary artery disease, like myocardial infarction. That's why people with chronic kidney disease, they can die from coronary artery disease, like myocardial infarction. Okay. Now, let's see this one here. 55-year-old man with hypertension and hyperlipidemia asked about the best dietary pattern for cardiovascular risk reduction after his recent non-STEMI. What diet has the strongest evidence? What do you think here, guys? That's very high yield, very important, very important. Amazing Chania, amazing Mayo, amazing Lemon, amazing Guys, whenever they ask about whatever diet to prevent hypertension, to prevent coronary artery disease, the best one is usually the DASH diet. Okay, the DASH diet. Okay, now what is this DASH diet? You don't need to know the components of it that much, but it contains like usually healthy fat. For example, olive oil, nuts. These are healthy fats that are usually not like the trans fats, which are very bad fats. Okay, and the other thing is that they contain vegetables, for example. They contain whole grains. You get most of your protein from a chicken and the fish. You limit the red meat because red meat is usually not that good. Do you know one of the things about red meat that I remember? Is that red meat increase the risk of a specific cancer. Do you know it? What cancer red meat increase the risk of? Amazing. Perfect. Again, I will try to ask you all these questions about nutrition. Red meat increase the risk of colon cancer. Red meat also increase the risk of gout, right? Gout. Because it has too much protein, which has too much purine, which has too much uric acid. Okay. So you will limit red meat. You will take olive oils, fruits, vegetables, legumes, which is usually like seeds, nuts, and whole grains. And it will decrease the risk of cardiovascular events by 30%. Okay, guys? So take care here. So the best for hypertension is DASH diet. Okay. Also, it contains very low sodium, which is very important. Now, let's see here. A 35-year-old man with recurrent calcium oxalate kidney stones has been restricting all dietary calcium. Despite this, he continues to form stones, and they're asking which dietary change is most appropriate to reduce stone recurrence. What do you think here? Yes, I love this topic. Amazing, Mohammed. Amazing, Thomas. Amazing, Rebecca. Yes, the answer was Mediterranean for last question, Mahmoud. Okay, I usually highlight the answers for you guys. Okay, so for this one, Emil, the focus here, Madia. The answer would be increasing the calcium intake a little bit until it become normal, until you give normal calcium intake. This person have been restricting all dietary calcium, which is wrong. For kidney stones, you need to give normal calcium intake. So you need to increase the dietary calcium intake until it becomes normal amount. Okay, and I will tell you why. Okay, I will tell you why. Okay, let's take it one by one here. The first thing, this person, whenever you are trying to up, like whenever you are having kidney stones, what are these kidney stones made of? Kidney stones are made of calcium and oxalate, right? These are the most common kidney stones. Now focus with me in this one, guys. Whenever you have in the GIT calcium, it usually bind to oxalate. And this usually cause calcium oxalate to be secreted in the stool, which is very good. Now, what can cause kidney stones? What can cause kidney stones is that either you have too little calcium or you have too much oxalate. So now this oxalate will be absorbed in the blood and will go to the kidney and will bind to the calcium in the kidney and will cause calcium oxalate kidney stones. And that's why calcium intake is very important to bind oxalate and to get rid of it in the stool. The way you think about it is that it's better for calcium to bind oxalate in the GIT rather than oxalate go to the kidney to cause kidney stones. Okay. Another way of getting calcium oxalate kidney stones is that if you have fat malabsorption, like in Crohn's disease, right, Carol? People with Crohn's disease, they have fat malabsorption. So they have fatty acids in the stool. These fatty acids, guys, will bind to the calcium. And this will cause oxalate also to be absorbed. Okay? So that's why people with Crohn's disease, they can get calcium oxalate kidney stones. So very few things here and there. Okay? The first thing is that if you are having too much oxalate, you can have kidney stones. If you are having too little calcium, you can have kidney stones. If you are having too much fat malabsorption, you can also get kidney stones. Other things they can ask about on the exam. Sodium and the protein. Sodium and the protein, you need to decrease them. Okay? Decrease them. Other things you can ask about. Citrate. Citrate, you need to increase it. So increase citrate, citrate is good. Decrease sodium and the protein. Okay? The last thing is fluid. Of course, the fluid, you increase it. Okay? So two things you increase it, fluid and citrate. One thing you keep it normal, calcium. And the other things you stop it, sodium, protein, and oxalate, guys. That's very important. And as Mohammed said, it's an amazing summary here, guys. Okay? What are the like the things you need to do? You need to give the person normal calcium, decrease sodium, protein, and oxalate, increase water and citrate. Okay, guys, that's very important. Now, that's similar to any stone treatment in general, Carol. Okay, we know cystine stone specifically happens in kids. It's a hexagonal in shape. Okay, it happens from malabsorption of the cysteine amino acids. But in general, for any stone, we need to do this thing, guys. Normal calcium, decrease sodium, protein, oxalate, increase water and citrate. Very important. Amazing. Now, let's see here. This one. A 29-year-old woman on isotretinoin develops nausea, headache, and papilledema on fundoscopy. What is the problem here? Is it vitamin A deficiency, vitamin D toxicity, hypervitaminosis, or niacin deficiency, or zinc deficiency? What do you think here, guys? Amazing. Perfect. Perfect, Maria. Perfect, Muhammad. Perfect, Iman. Perfect. Good, good, Rebecca. Good, Adel. So for this one, Adel, it would be hypervitaminosis, right? Why? I will tell you a few things here and there. Okay. The first thing is that vitamin A probably is the most important vitamin in the exam. So let's discuss it by details. Okay. Vitamin A toxicity can cause multiple stuff that I need you to know about. But the most important toxicity symptom of it is something called the pseudotumor cerebri. Or the other name of pseudotumor cerebri, which some students don't know that these are the same two diseases are what? Amazing. The one that happens in obese people, the ones that happen when you take oral contraceptives, the ones that can happen when you take tetracycline, when you take vitamin A, idiopathic intracranial hypertension. Amazing. The reason it's called pseudotumor cerebri because it can cause similar symptoms to tumors, increase in the intracranial pressure, can cause headache, nausea, and vomiting, which is similar to tumors, but it's not a true tumor, so it's pseudotumor. The reason it's called idiopathic because again, it's not caused by a tumor or blood or herniation or whatever. Okay. And it usually happens from vitamin A toxicity, obese females, oral contraceptives, tetracycline, and vitamin A. That's the first thing that I want you to know. The second thing is that vitamin A deficiency is completely opposite. Vitamin A deficiency will usually cause problems in the skin, like dry skin, problems in the eye, like night vision blindness, and usually spots on the eye called bitote spots. Bitote spots, which are white spots on the eye. So it affects the eye and the skin, dry skin and problems in the eye vision. Okay, and like keratomalacia, for example. Amazing. Now, that's the difference between deficiency and hypervitaminose. Another thing is that vitamin A itself is teratogenic, right? Teratogenic. And there is multiple reasons behind this. You don't need to know why it can cause problems in the neural crest migration, but you need to know that whenever we describe a person a treatment for acne, especially oral vitamin D, like isotretinoin, as you said, amazing guys, you need two proofs of, or you need to do HCG level, and you need two ways of contraceptive prevention, like for example, oral contraceptives and the condoms at the same time to prevent the teratogenic effect of vitamin A if she becomes pregnant. Okay. The last thing that it's very important, I used to say it in step one, but it's very important now in step two and step three, is that vitamin A is important to treat measles, very good. And it's very important to also treat acute myeloid leukemia. Okay, acute myeloid leukemia, which is ORODS. Okay, which has ORODS on it. Amazing, Mohammed. Okay, good, good, good. So vitamin A is important to treat measles, to treat acute myeloid leukemia, and to treat acne. Okay, very good. Now, one other thing that I wanted to mention, guys, about vitamin A, just in case, that it usually work inside the nucleus of the DNA, in the DNA itself. So vitamin A usually work on the nucleus of the cell in the DNA because it can cross the membrane because it's a fat-soluble vitamin. Okay, guys? So very important here. So these are all of the things you can ask about in vitamin A. Okay. So here it's vitamin A toxicity, which can cause intracranial hypertension. Okay. It can also cause hepatotoxicity. Now, last thing that I want you to know is that what can be a toxic dose more than 10,000. Okay. Do you need to know the dosage? I will tell you something. I just want you to know the dosage of folic acid. In pregnant people, you need to give them 400 milligram of folic acid if they don't have high risk of folic acid deficiency, like normal pregnant people. And you need to usually give them 4 grams of folic acid if they have high risk of folic acid deficiencies. Like, for example, they are taking valproate, okay, or they are taking anti-epileptic drugs. So 400 milligram for all pregnant people and 4 grams for high-risk people that are becoming pregnant. Maybe that's the dose that I want you to know, the folic acid dose, because usually it's important clinically. 400 milligrams for normal patients and 4 grams for people on valproate. Remember, 4 grams means 4,000 milligrams. Okay, guys? Now let's see here in this one. Pregnant, of course. Yes. Isn't folic acid is important in pregnancy, Reza? You need to give it usually 1 month before pregnancy, right? And continue it during the pregnancy. Okay, because it can cause neural tube defects if it's deficient. Now, let's see here. A patient on long-term proton pump inhibitors. What deficiencies are associated with chronic proton pump inhibitor use? Is it magnesium, calcium, vitamin B12, sodium chloride, vitamin C, folate, vitamin K, zinc, vitamin D, vitamin A, copper, potassium phosphate, vitamin E? What do you think? Amazing. Very good, Merz. Amazing, Nand. Amazing, Maria. Rebecca. Very good, guys. Perfect. Perfect. So for this one, guys, amazing, Silra, it would be magnesium, calcium, and B12. And I will tell you why. Proton pump inhibitors are very known of causing ions deficiency, especially magnesium and calcium. That's something we need to know. But what I also need you to know, guys, is that isn't the protein pump inhibitors can cause decrease in the acidity, and you usually need acid to absorb vitamin B12 and to also absorb iron. And that's why proton pump inhibitors can cause B12 deficiency and also iron deficiencies. Okay? And the calcium and magnesium. The last thing, proton pump inhibitors, isn't it decrease acid also? So it will cause acidity are important to digest fat and the food and to also kill bacteria. So if you use proton pump inhibitors, as Mohanna said, we will have an increased risk of C. diff, Clostridium difficile. And in the step 2 exam and step 3 exam, they are very tired of asking you about C. diff because they know that all the students know that C. diff happens after taking an antibiotic. So the new way of asking about it is that it can also happen after taking proton pump inhibitors and also after chemotherapy. After chemotherapy. A very good addition also, Collins, I love that you are guys adding informations to me, is that proton pump inhibitors can cause acute interstitial nephritis. Remember the 5B of acute interstitial nephritis. Painkillers, antibiotics like penicillin, rifampin, and proton pump inhibitors. Okay? So that's a few things here and there that we can go on, and I know we can go on and on about lots of things about proton pump inhibitors, like it can also cause cytochrome B450 problems. But I just want you to know like these few things here: magnesium, calcium, vitamin B12, iron, C. diff. Okay, so magnesium, calcium, and B12 because it decreases the gastric acid, which will impair absorption of magnesium, calcium, and B12, and P diuretics. Yes, yes, which can also cause acute interstitial nephritis. Now, let's see here another very important thing. So, long-term proton pump inhibitor use can cause hypomagnesemia. And if you get hypomagnesemia, guys, let me tell you about hypomagnesemia to high-yield stuff. Hypomagnesemia can cause resistant hypokalemia and hypocalcemia. If you see a person with hypokalemia or hypocalcemia, you give them calcium, you give them potassium, there is no improvement of their clinical pictures, there is no improvement on the level of calcium and potassium. Think about hypomagnesemia. The other thing that I want you to know is that it's the most common electrolyte abnormality in alcoholics. The most common electrolyte abnormality in alcoholic people is hypomagnesemia, and it will cause resistant hypokalemia and resistant hypocalcemia. So I will ask you, when you give a person with hypocalcemia calcium, no improvement, your next step of management is checking the serum magnesium. Checking the serum magnesium. Very important. Okay? So take care of this, guys. Now, let's see here. A newly diagnosed HIV is not yet on antiretroviral therapy and asks if she can breastfeed her newborn. In resource-rich setting, what's the best recommendation? What do you think? Breastfeeding is very important nutrition topic. So let's talk about it. Amazing amazing Madhya. Very good Iman. Very good at summer. Amazing. Amazing. Guys, if you have HIV, there is two questions. First, if you are in resource-rich setting and you can access formula, you need to use formula feeding because HIV will be contraindicated. But if you are in developing country, so there is poor resources, and you can't access healthy formulas, then you can do breastfeeding here. So in poor resourced countries, you can do breastfeeding, but take care the mother need to take antiretroviral therapy. But in resource rich, you already can get him formulas. So why do you need to do breastfeed if you have HIV? You need to use formula because breastfeed will be contraindicated. So here breastfeeding is contraindicated. You need to use formula in resource rich countries. It's an absolute contraindication, HIV. But in resource limited one, you can use it with taking antiretroviral therapy because the benefits outweigh the risks because they don't have clean water or clean formula. Okay, so in the USA, of course, you will do formula feeding. Yep. Other contraindications, guys, that are very important. Chemo and radiotherapy, untreated TB, substance abuse. And I wanted to ask you, so substance abuse, so morphine is a contraindication. But how about methadone? Active substance abuse, very good addition, history. How about methadone? Let's say the person is enrolled in substance abuse program and she is taking methadone. Amazing. Amazing. Perfect, guys. If you are taking methadone, then you can do breastfeed. Okay? Because the benefits of the mother feeling the baby around her outweigh the risks. So methadone is good. Like not good, but you can continue breastfeeding on it. But morphine or active substance abuse is bad. Of course, galactosemia, because you can't give the person any galactose, and milk have lactose, which has galactose, which can cause galactosemia, which can cause cataracts, jaundice, problems in the liver. Okay, guys. The next question, amazing, Rachel. If you have active herpes on the breast, you cannot breastfeed, right? It's a contraindication. How about if you have active acute mastitis? Acute mastitis. What do you think? Amazing. In acute mastitis, you just give the person antibiotic and you can breastfeed. Amazing. Perfect. You breastfeed. Very good. Very good, Charles. Very good, Helen. Very good, Andrew. Okay. Other things, guys, that breastfeed has IgA, which give immunity to the kids. Okay. And the breastfeed is also very important that it has, so it will give mucosal immunity. Yes. And it's very important to prevent many problems. Like literally, there is researches that it can prevent diabetes in these kids, for example. So breast milk is very important and usually always encouraged. Okay. We have 5 questions left, guys. Again, if you like this style and if you need more explanation of this topic or any other topic, you can try me or any of our amazing tutors for a free 30-minute session. And if you vibe with me, you can just commit to one of the packages. Um, but let's continue here and see the other 5 questions that are left for us. A 38 woman with 6 months after sleeve gastrectomy, developing nausea, abdominal cramping, diarrhea, and diaphoresis, 15 minutes after eating a large surgery meal. What's the diagnosis? I can see that the step one students that we have on our Synapse QBank and the course and that were attending with me last webinar are crushing it on the answers. So that's very good. So, yep. So amazing, Hardik. Good, Rebecca. Amazing, Carl. Very good, Caroline. Very good, Nanda. Amazing speed. So, yes, the pizza. Now, let me explain it for step two students without mentioning the pizza. So, here, guys, when you have gastrectomy, okay, when you have gastrectomy, what happens is that usually you are taking a food, and let's say it's a large meal. Usually, these large meals are supposed to go in the stomach, and then they stay in the stomach, and then they go one by one in the duodenum so you can absorb it. Duodenum and the small intestine. But the problem after gastrectomy, focus, focus, focus. You are giving too much food. This food will bypass the stomach and go directly in the small intestine. Lots of food goes into the small intestine. Okay? Your intestine will be very stressed, very surprised. They will increase the sympathetic nervous system. This will cause diaphoresis, hypertension, tachycardia. Okay? Also, all this food, imagine you have lots of food. Wouldn't it absorb fluid? So you give all this food, it will absorb fluid. It will cause osmotic diarrhea. The person will develop diarrhea. And this is called early dumping syndrome. You are dumping lots of food suddenly in the duodenum. This is causing too much sympathetic activation, diaphoresis, tachycardia, and the hypertension. And this is causing also diarrhea. Okay? It happens 15 minutes after eating a large meal. Now, especially sugary, of course. Now, few hours after this, what happens if you take a huge sugary meal? what will happen is that your insulin will rise. When the insulin go up suddenly, this will cause severe hypoglycemia, and this will cause hypoglycemic episodes, and that's called late dumping syndrome. So we have two dumping syndrome. A one that happens 15 minutes after, which is usually diaphoresis, diarrhea, all of this, and the one that happens hours after when you secrete too much insulin, which is hypoglycemia, called the late dumping syndrome. Very good. So early dumping, okay, is usually when you start to have the GIT symptoms and the sympathetic overload, diarrhea from the osmotic shift, and all of this. But late dumping, and when you have too much insulin secreted, and this is secreted from the too much sugar you are eating, this will cause reactive hypoglycemia later on. So if we said it happens from dumping too much food into the stomach, then the management would be small, frequent meals. Very important. Small, frequent meals, guys. Okay. And of course, you will need to avoid simple sugars. So try to get a complex meal that has protein, complex carbohydrates, and fat. Okay, guys? That's very important. Thank you, Summer. Thank you. I really appreciate it, and I really appreciate if it helped you guys. I know you are taking much time and dedication to attend these webinars, thank you for that. Um, so bile acid malabsorption, uh, SIDRA, is just one type of malabsorptions. Okay, what it will cause is that you are doing a surgery, for example, like a Roux-en-Y. Okay, and then you remove the terminal ileum, which usually absorb bile acid in the terminal ileum. What you will have is that now, when you are secreting this bile acid, okay, in the terminal ileum, this bile acid is important to absorb fat, right? So let's say you removed the terminal ileum, or you have problem in the terminal ileum, like Crohn's disease. What will happen is that now this bile acid will not be absorbed anymore, right? So you will have low bile acid. This will cause the first problem, which is usually diarrhea. The second problem is that this bile acid, doesn't it go to the intestine because it's not absorbed? When it goes to the intestine, guys, it will cause irritation of the intestinal lumen. This will also cause fat malabsorption and will also get diarrhea. So a person with bile acid problem, like problems in the terminal ileum, will get diarrhea by two reasons. The first reason is that this too much bile acid will cause fat malabsorption. This will cause fatty diarrhea. The second reason is that this too much bile acid will irritate the intestine because it's not absorbed, so it will go to the intestine, and it will also cause diarrhea. But it's only diarrhea syndrome. It's nothing as this. It's nothing as diaphoresis, for example, or hypoglycemia, or all of the other symptoms. So it's usually clear to differentiate between it. Okay. And let me just tell you about SIBO. So we just discussed all these weird things. What is SIBO? It's a small intestinal bacterial overgrowth. Not really an infection, Carol, but the way I think about it, imagine you did gastrectomy. Now your food is not going through the stomach, right? So now what happened to the stomach? The stomach is immobile. It's not moving because there is no food on it, right? And it usually turned into like a horror house, because there is nobody in it. There is no food on it. There is nothing on it. And whenever something is immobile and nobody is visiting it, bacteria will make parties into it. So bacteria will accumulate in the stomach and also accumulate in the small intestine. Let's say if it was like Roux-en-Y gastrectomy, for example. And this will cause this bacteria to accumulate and to grow and to grow and to grow. And that's called the small intestinal bacterial overgrowth. When these bacteria grow, they will cause two problems. The first problem is that they will cause diarrhea. The second problem is that they will cause B12 deficiency. Amazing, guys. Perfect. Perfect, Collins. Perfect, Hardip. And whenever I see a person after gastrectomy or row in Y, or for example, let's say they have diabetic gastroparesis. Isn't in diabetic gastroparesis your intestine are not moving? So also the bacteria will grow into it. So these people where they have either anatomical problem or function problem in the intestine, so the intestines are not moving, they will have small intestinal bacterial overgrowth. And this will cause two things, diarrhea and the B12 deficiency. And it's usually a diagnosis of exclusion. Okay, that's very important. Now, very good, Carl. Very good, Carl. Okay, yes, like in diabetes, for example, because we know diabetes affects the parasympathetic, so they will not be able to move your bowel. Okay, that will be the cause. Okay, amazing, Rebecca. Now let's see this one here, Rebecca. This question. Okay, an exclusively breastfed 2-month-old infant is brought for a well child visit. What supplementation is recommended? Focus this question usually get too many students the wrong answer on the exam because they didn't look at the timeline. They didn't look at the 2 months old. Thanks, Carl. Amazing Richard. Amazing Speeda. Amazing Collins. Very good, Cara. Amazing App. Very good. Amazing Tangent. So for this one, guys, it will be vitamin D. And I will tell you why. I will tell you why. Okay. First, vitamin K is very important to give it at birth. So it's not the one we give it at 2 months. We only give one dose at birth. That's it. So it's the wrong answer here. It's not recommended in 2 months old. Iron, we give it at 4 months. Do you know this? It's very important. Iron, we give it at 4 months in breastfed people. And then vitamin D, we just give it at the first few years in people that are exclusively breastfed because breast milk doesn't have vitamin D. Okay? Karim, but I remember that usually there was these ads on the televisions that whenever they do an advertisement for milk, they say this milk has too much vitamin D and too much calcium. It's because this milk they are advertising is fortified milk. Fortified milk has vitamin D, but breast milk doesn't have vitamin D. Okay, so that's very important to take care of. So vitamin D itself, you need to give it because breast milk contain insufficient vitamin D, guys. And this can cause rickets. Very important. Okay. On the other hand, the iron supplementation, you also need to give it, but starting at 4 months. Because at the first 4 months, you have enough iron from your mother. Okay? No, it's four more, Sharda. The more accurate is four, not six. Okay? And then the last thing is that formula-fed infants, they already have adequate vitamin D and iron because it's fortification. Last thing is early peanut introduction, usually reduce peanut allergy. They will tell you, for example, the person have family history of peanut allergy or egg allergy. What should you do to this infant? The wrong answer would be restrict peanut. That's the wrong answer. You need to introduce this peanut early on. This can decrease the risk of him developing a peanut allergy. So if they tell you that the infant, his mother has peanut allergy, how would you decrease the risk of him having it? You will do early peanut introduction. Okay, that's very important. Of course, when you give him peanuts, make sure like you pressure it and you smash it. You give it in like a powder formula. Because if you give him a large peanut, what will happen is that he will choke, right? If he is 4 to 6 months, he will choke on it. So take care of this. Now, yeah, but it's one of the choking hazards, right? It's very important. So don't to give him the full peanut. Okay. Now, let's see. For preterm infant side, And not specific changes. It's just you are just giving vitamin D by a larger dose and vitamin K a higher dose, and that's it. But no specific change you need to be aware of. And you need to give them more iron, of course, because they have higher risk of iron deficiency anemia. Okay. Now, let's see here in this one. A 5-year-old on a corn-based diet presents with symmetric photosensitive skin lesions, diarrhea, and confusion. What vitamin is deficient here? Amazing. Perfect, Raj. Amazing, Paula. Amazing, Maria. Amazing, Helena. Very good, Emald. Nandu, perfect. Perfect, guys. So it would be nice. And I will tell you why. This person having photosensitive skin lesions, that's dermatitis, right, Maiva? And also, that's a very important, Shamimar, is that they are having diarrhea and they are kind of having confusion, which is one of the symptoms of dementia. So diarrhea, dementia, dermatitis, in corn-based diet, that's vitamin B3 or NAS. Now remember, I told you I need you to know the other causes of vitamin B3. So here is the thing. Vitamin B3, guys, is usually sensitized from tryptophan. So let's say you have a disease called the carcinoid syndrome. In this disease, you are converting tryptophan to make serotonin. Wouldn't this decrease tryptophan level and cause niacin deficiency? So one of the causes of niacin deficiency is tryptophan. The second cause, or sorry, is carcinoid syndrome. The second cause is a syndrome called the heart nap. In this syndrome, guys, you can't absorb tryptophan and the other neutral amino acids in the kidneys. So you will have tryptophan deficiency, heart nap disease. This can also cause B3 deficiency. So carcinoid and the heart nap. The last cause is usually vitamin B6. Why? Or by the vitamin B6 deficiency. Because you need vitamin B6 to make niacin. So let's say you take isoniazid. Isoniazid can cause B6 deficiency, which can cause B3 deficiency. So that's why isoniazid can cause both B6 and B3 deficiency. It can cause B6, which can cause B3 deficiency. Okay, guys? So that's a few things about vitamin B3 deficiency. Please, for the love of God, don't confuse B3 deficiency with B3 toxicity, niacin toxicity. Niacin toxicity, guys, can cause what? Two increase in two things and one skin problem. Amazing. Perfect. 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 You told me all what I need, guys. Vitamin B3 toxicity, guys, will cause flushing from too much prostaglandin. So you treat it with aspirin. And it will also cause too much uric acid. So you also treat it with aspirin and non-steroidals. And it will also cause hyperglycemia, glucose increase. So niacin toxicity increase glucose, increase uric acid, and cause flushing, which you treated with aspirin. That's different than niacin deficiency, which will cause DE. So the DE, dermatitis, dementia, diarrhea is deficiency, but flushing is toxicity. Now, you will tell me, but Karim, who can get niacin toxicity? People that are taking niacin to increase their HDL level. Sometimes niacin is given to increase the HDL. Remember, for LDL, we give a statin. For triglycerides, we give fibrates. For HDL, if we need to increase it, HDL is the good lipoprotein, we give niacin. So this can cause niacin toxicity if you are taking too much of it. That's the thing. Okay, guys? So differentiate between dementia, dermatitis, diarrhea, that's deficiency, from toxicity. Okay, guys? From toxicity. Very good. Very good. Now let's see this one here. A 9-month-old exclusively breastfed infant is brought to the clinic because of delayed sitting and the poor growth. Physical exam shows widened wrists and bowed legs. X-ray demonstrates metaphysical cupping and fraying. Which of the following laboratories patterns is most likely to happen? Take care here because lots of students will confuse this one. Amazing. Very good, Rebecca. Very good, KG. Amazing, Nelson. Welcome back. I believe you attended a little bit either later on or you were not answering me earlier, Nelson. Very good, Sneha. Amazing, Marie. Very good. Amazing, Imad. Amazing, guys. So for this one, this person is exclusively breastfed, and they are having, when you see this fraying and the cupping on X-ray, or when you see, for example, this widened wrist and bald legs, think about rickets, vitamin D deficiency. And lots of students confuse vitamin D from parathyroid hormone. If you have vitamin D deficiency, guys, you can't absorb calcium and phosphorus in the GIT. So both calcium and phosphorus will be low. And this will cause too much parathyroid hormone to compensate for the low calcium. Okay? But the idea is vitamin D is important to absorb calcium and phosphorus, both of them. But parathyroid usually increase calcium only and decrease phosphorus. So don't confuse them together. And usually rickets happens when you have low calcium and low phosphorus, both of them, especially phosphorus, by the way, because sometimes the calcium can be normal from the too much parathyroid. So the problem is mainly even the low phosphorus. People think that rickets is only about calcium. No, phosphorus is the main important stuff, low phosphorus. And this will cause problems in mineralization of the bone. You need these minerals in the bone, and this can cause rickets or osteomalacia. That's different than osteoporosis, which is bone density. Bone density. Okay. So here, that's a vitamin D deficiency, which will cause decrease in the calcium and the phosphorus, guys. Okay. That's why you need to supplement people with 400 international unit per day. It's similar as 400 milligram for folic acid. So just remember both of them 400, guys. Okay. Folic acid in pregnant people 400 and 400 in the kids in the units, sorry. Okay. Another very important thing is that in adults, we call it osteomalacia. In adults, we can call it osteomalacia. Okay, very good. Very good. That's it, guys. Okay. Again, I try to contain few things here and there in the nutrition. The first thing, and I know we can't cover all, but when I did it in step one and it was 2 hours and a half, it contained much more stuff. But I know for step two, you can get tired much easier. Okay. So I try to contain only the high yield stuff, what I think is important from the basics that can be important here. Okay. And the last thing is that I tried also to contain the things that I think repeating a lot on the nbmes, for example, or that they can add and ask about that are new in the nutrition itself. I will try to update this recording in our YouTube channel. I will send you the link. Okay. And here is the link for our Telegram channel, so we can also talk with each other if you need anything, and our tutors can help you on it. This is a Telegram channel, and probably I will send you also the YouTube channel itself. 1 second, and I will try to update the recording on it. Okay, guys? It's called just the Matchguy YouTube channel. Okay. Um, you just increase the dose in preterm infants with iron sides. Okay, that's the thing. Um, and here, that's our YouTube channel. Okay. Thank you guys so much. Take care. We are doing these webinars every week. Okay. And we are trying every week to contain a high yield topic here and there. So you can even join the Telegram and maybe recommend to me what topics you want us to discuss next. And any feedback, I would really appreciate it, guys. Okay. Thank you so much. It was very helpful. Hopefully I will see you again in my next webinar. Okay. Thank you guys so much. Bye bye. You are amazing. Bye bye.